Subcoracoid impingement. This is the impingement of scapularis between coracoid and lesser tuberosity. Coracoid has the following muscle attachment. Number 1, coracobrachialis. Number 2, short head of bicep. Number 3, pectoralis minor. Ligaments attached are coracohumeral ligament, coracoacromial ligament, and coracoclavicular ligament. For subcoracoid impingement, the diagnostic can be a coracohumeral distance if less than 6 millimeter, considered abnormal. Treatment is ultrasound guide injection. Most of them managed conservatively, except for some which needs coracoplasty plus minus subscapularis repair if there is a tear with it. Subcoracoid coracoplasty can be done open or arthroscopically. Like regarding subacromial impingement, causes can be anatomical or functional. Anatomical means there is a bony spur, thickening of acromoclavicular ligament, or a bursa, or also acromial. Functional means the problem is in the muscle, for example, poor cuff control. Biglani classification, type of acromion, flat, curved, hooked. Acromion ossification centers, metaacromion, mesoacromion, and preacromion. The patient is subacromial impingement. Examination findings will be positive. Regarding the management guidelines, a true AP view to evaluate acromiohumeral interval. The normal distance is 7 to 14 mm compared to the other side. Regarding the management, it's BOA care pathway. Non-operative management should be given for a minimum 3 months. If operative intervention, should avoid acromioplasty and coracoacromial release, because to preserve coracoacromial arch in patients with massive and irreparable rotator cuff tears. Seesaw trial, Ken shoulder arthroscopy work trial 2018. Number 1, surgical group had better outcomes for shoulder pain and functional compared to the no treatment group, but this difference was not clinically important. Number 2, surgical benefit offer no extra benefit or when compared to arthroscopy only. Number 3, the difference between the surgical and non-operative group might be result of placebo effect. If the os acromial is a small fragment, you can consider removal as well. There is another form called internal impingement. The internal impingement happens when the intra-articular surface of the posterior supraspinatus impinges against the posterior superior glenoid. This happens with players who have abduction external rotation position. In abduction external rotation position, the posterior rotator cuff impinges on the posterior superior labrum. This is associated with glenohumeral internal rotation deficit. These are in repetitive throwers, increased external rotation with decreased internal rotation, and a pasta lesion. Pasta is partial articular side supraspinatus tendon avulsion. Treatment is posterior capsular stretching with sleeper stretches. Arthroscopic repair or posterior capsular release is also advisable.